We have the lovely pleasure of having Dr. Nikkil with us. So just to give you a bit of background, he's an Alexander von Humboldt Fellow and Research Group Lead at the Heidelberg Institute of Global Health. His research draws upon behavioral sciences and health services research to improve the prevention of cardiovascular diseases in middle-income countries like India, Indonesia, and Cambodia. Nikkil's received his PhD from the University of Pennsylvania, and he was a David E. Bell postdoctoral fellow at the Harvard T.H. Chan School of Public Health. We're really excited. If you have questions along the way, please feel free to put them in the chat. There may be some time at the end as well, and we can answer them. But yeah, okay, over to you, Nikkil.
Thank you so much, Shirley, and thank you everyone for attending the talk. It's a real privilege to be able to share some of this work. So I'll start off by saying that I can't take solo credit for any of the work today. It's really an overview of things that I'm working on with my colleagues. And so really I'm presenting on behalf of myself and all of them. So to start right away with the motivation for this, I think very clearly, reducing mortality in low and middle income countries is a major global policy goal. You can see this in the Sustainable Development Goals, and I don't think it actually needs to be codified. It's something that everyone kind of agrees on. But I think middle income countries, places like India, Indonesia, Cambodia, they're undergoing some transitions that are really important and I think will really influence what we prioritize. So the first is that the countries are rapidly aging. So what this means is that child mortality has actually declined substantially. So if we want to continue making progress against mortality, future gains will have to come from adulthood. And then we also see population aging in terms of not just mortality, but the movement of very large birth cohorts into middle age. So this almost mechanistically will mean that adult mortality is inevitably going to increase as a share of overall mortality. So given these big kind of population trends, I think an important question is what should be prioritized and where should we start? So obviously I'm going to argue throughout this presentation that I think high blood pressure is a really, really promising place to start. But to try to motivate that a little bit more, we know from clinical trials that were conducted in high-income countries that reducing blood pressure substantially reduces cardiovascular disease mortality. It is one of the most effective and cost-effective ways we have of preventing cardiovascular mortality. And in middle-income countries, what we're starting to see now from surveys is a very high prevalence of uncontrolled hypertension among adults. So I'm going to highlight two facts here, one from India and one from Indonesia. And I think this is pretty shocking that if you look among adults older than age 30, about 30% have uncontrolled hypertension. And this is kind of reflected in the age structure changes as well. So we tried to, with my colleague Pascal Geldsetzer, say, like, if hypertension stays the way it is in terms of its risk, but we have a very rapidly aging population, what's going to happen to the number of individuals that need care for it? And we find really alarmingly that aging is going to more than double the number of individuals with uncontrolled hypertension by 2050 in just 30 years. So this is really like a massive increase in the number of people that are going to need treatment for this. And we think this is reflected in the mortality profile of these countries as well. So if you look at places that actually have some form of directly measured cause of death data, not GBD modeled, but actual cause of death data, like India and its sample registration system, cardiovascular diseases are already the leading cause of death among rural and urban populations. So we're already really seeing this transition. It's not something that's going to happen, it's already here. And so while this seems like I'm painting a very dire picture here, I actually think there's another way of looking at it, in that there's tremendous potential to improve longevity in these contexts by addressing high blood pressure. And blood pressure in particular, I think, is really appealing because it's also a feasible way of averting a lot of early deaths. We know that it's highly effective. The medication is widely available in most places. It's affordable and comparatively to other treatments has minimal side effects. So this is a talk on the behavioral challenges of controlling high blood pressure. So I wanted to start right away by highlighting some of the work that I'm doing with Mike Ebert, a PhD student at Harvard, and Maggie McConnell, who's a behavioral economist at Harvard. And we are trying to look at why is it that NCDs are so challenging to control? And I think the best way to illustrate this is to contrast NCDs like hypertension and cardiovascular disease to infectious diseases, the kind of types of diseases that middle-income countries are most used to dealing with. So if we start with infectious diseases here, in many cases, there's a clear cause of the illness. It's a mosquito or it's contaminated water. This leads to very clear symptoms. You have a fever, you have gastrointestinal distress that really signal very strongly to individuals that they need some form of care. You start to feel really ill. Treatment can then be done in short-term, one-off interactions. So if it's something that's bacterial, and you can take antibiotics, or you take basically ORS or something like that, and the treatment is not something that has to usually be taken over a very long period of time, and usually the treatment resolves the illness. And then the treatment can be stopped. So it's kind of, in many cases, this very clear chain of events when we're talking about caring for and treating infectious diseases. In contrast, though, non-communicable diseases, they first of all start with ambiguous, unknown, or multiple causes that accumulate over an individual's lifetime. So for individuals, they find it hard to attribute it to one singular thing. It's kind of a cluster of factors that can lead to the development of non-communicable diseases. And most importantly, conditions tend to be asymptomatic until they're very, very advanced. This is especially true for hypertension. It basically remains asymptomatic until you have a stroke or your blood pressure gets so high that you start feeling headaches and things like that. But that's really at an extreme level. So in the absence of symptoms, then care needs to be provided to actually detect these conditions. And because individuals may not be showing up with symptoms, this has to be done proactively or opportunistically. And then rather than treatment to cure, you have treatment to manage. So it's really behavioral change and treatment have to be taken in the absence of symptoms. It requires regular follow-up visits and long-term follow-up, and it really can't be stopped. So once you have hypertension, in almost all cases, for example, you have to treat it for the rest of your life. So this is a very different type of framework from infectious diseases that I think leads to a lot of behavioral challenges for both clinicians and patients. So I'll start today with talking about the clinician and the work that we're doing on this side. If you look at what a clinician actually has to do behaviorally, the type of care they have to provide, they have to proactively or opportunistically screen patients for NCDs and the risk factors. And this is because they're asymptomatic. Most people are not going to show up saying, I feel like I have high blood pressure, or I feel like I may have undiagnosed diabetes. It's really something that physicians have to, they can't take a cue from a patient, they have to be doing this proactively. They then, if someone screens positive, rather than just give a one-off treatment, it's really, there's a big counseling and education component of this care. They have to provide a lot of information to individuals on why these NCDs need to be managed. And they have to provide information on what the best ways of managing them are and the importance of things like adherence and long-term follow-up. And then they actually have to follow up and treat and monitor patients over time. So it's no longer the case that you can provide kind of one course of medication and then say, it doesn't matter if I see the patient again. You really need to have a system to track patients over a long period of time. So this immediately can create some behavioral challenges for clinicians. And I'll highlight a few that we've talked about here. The first are just clinical knowledge. Clinicians just may not know how to provide NCD care. And this is especially true in contexts where medical education is really focused on infectious conditions. And there's also not a lot of continuing medical education. There's issues of what we call inertia, attention, and habit. And this is just that if you're a clinician that's used to providing a lot of infectious or one-off care, providing NCD care is quite different. So it doesn't come as easily and as automated as other types of care would. So it really takes a lot of focus to try to change the way you provide care. This is an interesting thing that I'll talk about in a little bit. Clinicians may actually not believe that patients value NCD care. They may think that patients just want an injection and then to be out. And in that circumstance, they may actually have a perception that because the patient doesn't value it, they don't need to provide it. And finally, the health system itself may just impose frictions. There's really not user-friendly systems to track and monitor patients, and things like electronic health records are still kind of few and far between. So to start right away with knowledge, I want to highlight an ongoing study we're working on CVD screening and risk assessment in Cambodia. And this is work that's being done as part of a larger evaluation of a big health systems improvement project in Cambodia funded by the World Bank, KfW, which is the German Development Bank, and other big international donors. So we had a very simple question. We wanted to know in the public primary care system, what share of clinicians are actually providing guideline recommended CVD assessments? And if we observed a gap, which I'm foreshadowing we're likely to, was this due to just clinical knowledge, or is there something else that's standing between knowledge and action? And so what we did was we collected data from 114 public primary health centers across the country. And within each health center, we collected two forms of data. So the first are something known as clinical vignettes. And this is essentially, we go to clinicians and present them with a hypothetical patient. We say a 40-year-old male is visiting your clinic complaining of back pain, for example, what would you do? And we don't really prompt the clinician beyond asking them, like, what type of questions would you ask? What type of tests would you run? What type of treatments would you prescribe? So this gives us a measurement of what clinicians kind of know about opportunistic screening. Remember, they really should be providing these things to all adult patients, not just those that show up saying they need hypertension care, because that'll be really rare. The second thing we have, and what we complement this with, is patient observations. So we actually station an enumerator in the room and have a checklist of what clinicians did during their consultations. So using these two forms of data, we're constructing what's known as the no-do gap. So basically we have what share of patients are receiving guideline recommended care in the vignettes, or in actual care. And this is a measurement of what clinicians do because we're observing their care with real patients. And we're going to compare that to the share of clinical vignettes where the clinician correctly screens for hypertension and diabetes and assesses CVD risk factors. So the vignettes really reflect what a physician knows, and what they do with real patients reflects their behavior. And we want to contrast these two things and see, is there a discrepancy between their knowledge and their action? So I'll start right away with the results here. The graph is going to show 4 screening actions: whether the clinician measured blood pressure once, so at all, whether they measured it at least twice, which is actually how you're supposed to measure blood pressure, because the first reading often has what are known as white coat effects. If people show up at a health facility, their blood pressure can be artificially elevated just from having shown up and sitting in a doctor's office. So really all the guidelines recommend that blood pressure be measured twice at least. Was their blood glucose measured to test for diabetes? And was their BMI measured to see if they were overweight or obese? And I'm going to present the results for both the vignettes, so what the clinicians know in theory, and the observations, what they actually do in practice. And this is work that's done with Sarah Wetzel and Till Berninghausen at Heidelberg, the Cambodian Ministry of Health, and Angkor Research and Consulting in Cambodia. So starting right away with blood pressure measured once, we actually see that most clinicians in both the vignettes and in real practice measure blood pressure at least once. Yeah, there's a tiny no-do gap, but overall they're doing a good job. But where things start to drop off right away is that measuring blood pressure at least twice. We're seeing that even in the vignettes, only about a quarter or a fifth are actually saying they had measured blood pressure twice, and less than 10% in terms of actual patients. So this is really a huge drop of correct blood pressure measurement right from the start. What we see in blood glucose is evidence of a really, really, really massive no-do gap. So in the vignettes, almost all physicians are saying that they would measure a patient's blood glucose, but among actual patients, they basically never do. We see a similar story for measurement of BMI. About 3/4 of clinicians say they would measure BMI in the vignette, but only about 10% actually do with real patients, a really large no-do gap. If we then look at CVD risk assessment items, whether they asked the patient about their diet, whether they asked about physical activity, their alcohol consumption, or smoking, I can already foreshadow here for you that you see the axis only goes up to 40%. So it's already going to be lower. But you see, interestingly, that they actually ask patients more in real life about their diet than they do in vignettes. But even so, only about 1/3 of patients are asked about their diet. Less than 10% are asked about physical activity. And yes, there is a no-do gap, but even in the vignettes, when we measure knowledge, it's only about 1 in 5 that know to ask physical activity. Alcohol consumption is a little bit higher in the vignettes, but again, among actual patients, it's still very low. And a similar story with smoking. So here what we're observing is, yeah, there's small no-do gaps, but it really seems that the absolute levels, even in terms of what clinicians know, tend to be quite low. So this was just a baseline assessment that we were doing in Cambodia. And what we found right away, though, is that there's pretty big implications for care in the country. Right away, we're finding that correct blood pressure measurements are a major knowledge gap. And as I alluded to earlier, if you're measuring blood pressure just based on one measurement, like most clinicians are, it's likely to result in a lot of measurement error for hypertension, a lot of false positives. So this could actually mean that in Cambodia, a lot of people are getting falsely diagnosed or falsely put on treatment because hypertension is really only being judged based on a singular measurement. So that's really inefficient and may lead to over-treatment. With diabetes, though, we see this huge no-do gap. And what this implies is that basically all diabetes is being missed in the primary healthcare system in Cambodia. That because nobody's getting measured for it, there's potentially lots of people with undiagnosed diabetes that are just not getting initiated on treatment. And that's really problematic and worrying. And with these questions on risk, things like physical activity and diet, I think the way to look at it is by not asking these questions, not everyone might be overweight or not everyone might be a smoker, but by not even asking the questions, clinicians are leaving potential for prevention on the table. So this was, like I said, just a descriptive study, but I think right away it really signals that for some things, it's not always knowledge and it's not always a knowledge behavior gap, but in many cases, there is a gap between what physicians know and how they behave, especially for things like diabetes screening. So I apologize for jumping between countries here. But to investigate this gap, like why is it that physicians or clinicians may know something, but not actually act on that behavior? I want to talk quickly about a study that we're designing in India. In the Indian context, like many middle-income countries, has kind of a couple unique facets that might influence a clinician's behavior. So the first is that they're paid per patient or on a fixed salary. So this means they don't really have strong financial incentives to screen patients, nor do they really face repercussions from not screening. There's really not quality control or audit mechanisms in place. So in this context, clinicians may only be inclined to screen patients if they actually believe that patients value it, because this will lead to a better reputation, more patients. And in that moment, a clinician might feel that they feel kind of good if the patient is satisfied because they're providing the care that the patient wants. So in this case, if clinicians believe that patients don't really value these type of care, they may not do it. And that's, I think, relating to that biased beliefs thing that I talked about earlier. The other aspect is clinicians in India and in many middle-income countries really see a substantial number of patients. The study that I saw estimated that consultations are on average less than 2.5 minutes long. So if you think about CVD screening actions, taking multiple blood pressure measurements, measuring BMI, asking a bunch of risk questions, that's really pretty time consuming. So when you're under this very extreme time pressure, physicians may simply just skip the screening actions in favor of seeing more patients. So what we wanted to know right away is, can patients signaling that they value screening improve care? So to that first potential mechanism, if a patient says, you know, I really would like my blood pressure measured, or I'm really concerned about this, will the clinician then interpret that and say, oh, okay, I may gain some reputational benefit from doing this because the patient wants this? Similarly, for the other mechanism, if you alleviate time pressure on the clinician, say through a waiting system or a queuing system, will it lead to better care because clinicians don't have to move so quickly to see so many patients? So rather than actually design really big, complicated interventions to test this, we tried to initially wanted to see if these hypotheses are even correct with what we think is kind of a novel study design. So what we're doing is using a mystery patient or standardized patient study. So rather than send real patients, instead we want to train field workers to pose as patients that seek care in a standardized way. These mystery patients would then visit actual clinics and seek care like a real patient, except they note what actions the clinicians took. So in this case, we're not biasing clinician behavior because they don't actually know that they're being evaluated. They think they're seeing a real patient. And this approach has really been pioneered in India by Jishnu Das. He's done many studies on this, and Madhukar Pai recently for tuberculosis as well. And the cool thing about the mystery patient study is because we're training these field workers to pose as patients, we can experimentally vary aspects of their visit to try to see if there's any merit to these mechanisms that were asked, these two questions. So for example, we don't have to actually do a big intervention and then measure patients. We can actually use aspects of the mystery patients themselves to see if the mechanisms or the hypotheses are worth pursuing with an intervention study. And I think one thing in particular we wanted to use a mystery patient study for, we were told by lots of people anecdotally that if you go to a clinician and kind of overturn their advice or confront them on their advice and say, like, I really do think I should be screened for hypertension, in many cases, the clinician may actually react very poorly. And we have heard instances of the clinician actually like yelling at the patient. So before we send real patients into that type of environment, we wanted to see, can signaling to the clinician actually improve care, or will it actually lead to reactance? And so that's another justification for the mystery patient design. So I'll quickly talk you through this. It's not super complicated at all, but we're aiming to do this in 1,200 primary care visits in both the public and private sectors. And the first question, does patient signaling influence physician care? We'll get at this by randomizing the patients to present one of two cases. A control case where the mystery patient shows up claiming that they just have a common condition like back pain or fatigue, and they don't signal anything like hypertension. And then a treatment case, if you will, where the mystery patient will show up and actually seek care specifically for hypertension, claiming, for example, that their blood pressure was elevated when it was measured at home and they're kind of concerned. So this is because we're experimentally controlling this, we can see whether that signaling has an effect on physician care. Very similarly, if we want to understand the role that time pressure has, we want to take advantage of the fact that clinicians often have multiple clinical hours, some that are more high volume than others. So what we'll do is send randomized patients to visit the same clinician, but at two different times. So one mystery patient will seek care during a low patient caseload time when they have less time pressure. And then we'll randomize some mystery patients to seek care during a high volume time. And because they're identical patients, we've kind of fixed that aspect of it. We can attribute any difference that we see in care between these two to the time pressure aspect. So ultimately, this experimental design leads us to 4 mystery patient cases, crossing high time pressure, low time pressure, and whether the mystery patient expresses concern and hypertension or not. And because all of this is experimentally done, very simply, if we want to know, for example, the impact of time pressure, we can compare the outcomes for these 2 cases to these 2 cases. And if we want to know the impact of signaling to the clinician that you value screening, we can compare the outcomes from these 2 cases to these 2 cases. So outcomes, we're looking very simply at, did the clinician measure the patient's blood pressure at all? So this is kind of capturing any opportunistic screening. If so, did they do it correctly? Did they take at least 2 measurements? And were these measurements at least 5 minutes apart? And on the off chance that our fake patients, our enumerators, actually present with a blood pressure that's in the potentially hypertensive range, did the clinician ask them to come back in 2 to 4 weeks for a second measurement? So that's really what they're supposed to do to diagnose hypertension. So we think this study is actually kind of simple but cool at the same time, and it's addressing what is a pretty major blind spot in current research, and that's clinician behavior. I think when you look at NCD behavioral research, it's really, really focused on patients and not so much on acknowledging the fact that clinicians are also humans that face biases and have to make decisions. So we hope that they can inform interventions by revealing whether these pathways of whether time pressure and signaling are actually meaningful ways of moving the quality of care that patients see. But this is also quite important in India because the Ayushman Bharat is being rolled out, and it's really one of the biggest primary care expansion policies in the world. And a big part of it is to improve the prevention of cardiovascular diseases at the community level through opportunistic screening, this exact mechanism that we're evaluating here. So ultimately, how effective this Ayushman Bharat program is, if you're thinking of like implementation science research, will really depend on how clinicians are behaving. So you could have a perfect program, but if clinicians are not actually screening, then it's not going to be detecting and preventing cardiovascular disease as well as it should be. So now to the other side of the coin, I want to talk briefly about studies on the patient side. So let's actually start before getting into behavioral research on this. I think it'd be interesting to talk about how traditionally care gaps for non-communicable diseases are looked at, and that's with this care continuum model. So I'll walk you through this for Indonesia. in these continuum models that have really come up a lot, you've seen a lot of continuum of care papers now in many countries. You take a country like Indonesia and you look at all individuals that are hypertensive, and then you trace them through the stages of care, through diagnosis, treatment, and control, and see how large the drop-offs are at each stage. So for example, in Indonesia, among all adults that are hypertensive, only about 35% are diagnosed. Only about 25% are treated, and just 7% have treated and controlled blood pressure. So this has really become the guiding framework for how we think about care gaps for non-communicable diseases in many middle-income countries. And it's often estimated this way with cross-sectional data. And the reason I'm bringing this up is, while this seems really powerful, I think this can be really misleading in a way too. So I want to walk you through why I think that is. The first question is, this type of framework doesn't really tell you how individuals arrived at a particular stage. So if we go back here, of this 25% of hypertensive individuals that are on treatment, we know that a bunch of them, 75% of people, are not taking treatment. But we don't really know how many of these people never initiated treatment versus those that were taking treatment before but stopped. And that's really important because the policy interventions we think of for getting someone to initiate treatment might be very different from those that we think of for getting someone to stay on treatment once they've initiated it. We also don't get a picture of how sticky, if you will, these stages are. So we have these treated and controlled stages, but of the 7% of hypertensive individuals that are in the controlled bucket, how many of them will actually stay controlled in the long run? Because ultimately for NCDs, that's what really matters, is long-term control. Similarly, how many of these individuals with treatment will stay treated long-term? These kind of cross-sectional continuums that have come to really dominate NCD care gap research don't really provide any indication about these questions. And the third is a little bit tricky, but I'll try to walk through this, that the cross-sectional pattern we see in this data does not actually equal an intervention effect. What I mean from that is, if you were to look at this, I think any reasonable person looking at this would say most people are not diagnosed. 65% of those individuals are not diagnosed. But if we look among those that are diagnosed, around 70% are on treatment. 25% are treated among the 35% that are diagnosed. So about 70% of those diagnosed individuals are on treatment. And I think if you look at these cross-sectional data, it leads to it kind of suggests very strongly that diagnosis is the solution, that once we start improving diagnosis, things will fall into place. And this is really where the field has started to head, that it's all about improving diagnosis and detection. And I think it's partly because of these type of continuum figures that lead to that policy conclusion. But because this is cross-sectional data, the people that are in the diagnosed and treated buckets are fundamentally different groups of people than those that are undiagnosed. So what this means is the proportion of people in the cross-section who are diagnosed and take treatment, that's 70%, does not actually equal the proportion of undiagnosed people that would take treatment if you diagnose them. So this is a little bit of like a mental somersault, but maybe one way to think about this is, in a context like Indonesia here, if you're already diagnosed and treated, you could think you're very advantaged relative to those that are undiagnosed. So the undiagnosed population might be more disadvantaged. So providing them a diagnosis may actually not lead 70% of them to initiate treatment in the way that we see in the cross-section. So this was an open question for us. The cross-sectional nature of this, I think, really skews the policy conclusions. So we wanted to know longitudinally, how do individuals with hypertension move through the continuum over time? And what does this reveal about where we need to intervene? And this is a project that's being led by Nikkil, who's a doctor medical student. It's kind of Germany's medical doctorate at Heidelberg, with a really big co-authorship team from people spanning multiple universities. This is under review right now, but we have a preprint up and we'd really love your feedback. And that's something I'm happy to talk about more in the Q&A. So this paper, I showed you just Indonesia, and today I'm going to stick just to Indonesia, but we actually look at longitudinal data from 4 countries, China, Indonesia, Mexico, and South Africa. And we basically look at 4 groups of individuals, those that are undiagnosed and uncontrolled, those that are diagnosed but are not taking treatment, those that are diagnosed and treated, but for some reason still do not have controlled blood pressure, and then our ideal group of those that are diagnosed, treated, and their blood pressure is under control. And our methods are super simple. we're basically looking at what is the probability that people move between these different stages, between our baseline and follow-up waves. We also investigate these kind of more clinically meaningful transitions, like what is the probability of becoming diagnosed among the undiagnosed or initiating treatment among the untreated. But we're also looking at these backwards steps as well. What is the probability that people lose control over time? Or what is the probability that they stop treatment that they had previously been on? So I'll walk through this graph really quickly. So again, I'm showing results here for just Indonesia, but if you want to see them for the other countries, I'm happy to share the preprint that we have with this for all 4 countries, but the patterns are broadly similar for all. So I think it's easier to focus on just one country. So what I'm showing you here on the left is the state that individuals are in at the baseline wave. So at baseline, they could be undiagnosed, diagnosed and untreated, treated and uncontrolled, or treated and controlled. And the x-axis here shows you what stage they end up in at endline. So there's a small percentage of undiagnosed people that actually go back to being normotensive, and we think that's just because of blood pressure error. But then, for example, you could stay undiagnosed. At endline, you could be diagnosed and untreated, and they're the same stages. So what this graph is really showing is what are known as transition probabilities. So I'll just walk you through it really quickly for the undiagnosed column, for example. This first cell that you see of 52% in the top row, that basically means among those that were undiagnosed at baseline, 52% are undiagnosed at endline. They're remaining undiagnosed. That 20% tells you that among those that are undiagnosed at baseline, 20% became diagnosed but are untreated. So there's a lot of numbers here, but I want to highlight a couple patterns that I think speak to this gaps with cross-sectional cascades and continuums that I was talking about earlier. So the first thing, if we look at the proportion of people that were undiagnosed at baseline that end up in some form of diagnosed or diagnosed treated or diagnosed treated and controlled, what we see here is that 30% were diagnosed by endline. So the vast majority remained undiagnosed. But only 33% initiated treatment among those that were diagnosed. So here we have a huge discrepancy between the cross-section, which said that if you diagnosed people, 70% would initiate treatment, and what happens when you trace actual people over time. Here, even though 30% of people were diagnosed, only 33% of those that were diagnosed initiated treatment. And perhaps most shockingly, just 3% of those individuals that were diagnosed actually reached a controlled blood pressure state. So diagnosis is not acting as the silver bullet that we think it is. Basically, no one is getting to controlled blood pressure among those that are diagnosed.
Nikhil, sorry, stopping you.
Yeah.
Just curious how this transition would look like in a different country, well-developed country, probably.
Yeah, so in the funny thing is actually in developed countries, diagnosis leads a lot more to the initiation of treatment. And then there is this about 50% of people who are diagnosed take treatment, and about 50% of those that are treatment reach controlled blood pressure. So it's still not great. Yeah, it's that rule of halves. It's still not great, but it's much, much better than this.
Yeah, okay.
So I think the other interesting thing to look at is if you start at those people that were treated and controlled at baseline, the people that at baseline were in the ideal state, 92% of them lost blood pressure control by endline, and 82% stopped treatment altogether. So the state isn't really sticky. It's not the case that once you get people to a treated and controlled stage, kind of your job is done. We're really seeing quite the opposite, that there's a lot of effort that needs to be involved in keeping people treated and keeping them on treatment and having blood pressure controlled.
This was, you did it over what period of time, like, and how many measurements?
Yes, this is a 6-year period. And there's 3 measurements at each point, but we use the average of the second 2. Yeah, so I'll highlight one more, just one last pattern here. If you look at all those individuals that were treated at baseline, 75% discontinued treatment. So we really have large backwards movement in the continuum, if you will, from people who are starting at the good stages at baseline. And those that are starting at the undiagnosed stage, diagnosis isn't really leading to these huge improvements. So what we're seeing here, I think, is the conventional wisdom that if you improve diagnosis, everything else will fall into place, at least in the case of these 4 countries, isn't really true. as I just said, about a third of people that were diagnosed were initiated treatment. And that's compared to that 70% in the cross-section, if you look at the cross-sectional cascade. And the dynamic treatment also reveals really substantial backwards movement. So 75% of treated individuals stopped treatment, and 92% of those with treated and controlled blood pressure lose control over time. So to now jump back to behavior science, how do we understand this, I think, is the big question. And I'm showing a similar type of thing that we talked about earlier for clinicians, this time for patients. If you think about what a patient to do, they need to seek, screen, even in the of symptoms. They then need to make multiple follow-up visits to get their conditions diagnosed and their treatment titrated correctly. And then once it's titrated correctly, they have to have follow-up visits over a very long term to ensure that their blood pressure or their blood sugar stays controlled over time. They often have to make difficult lifestyle changes like losing weight, changing their diet. And these are lifestyle changes they have to make in the absence of feeling any real symptoms too. And they have to adhere to lifetime treatment regimens. So once you initiate hypertension treatment, for most patients, you can't really stop. So this is really different from infectious conditions where there's just kind of a course and then you stop. So for individuals, there's a lot of reasons why we think this could be challenging. The first is the kind of classic problem of forgetting or inattention. And that's really because these conditions, because they're asymptomatic, they don't really provide clear signals to individuals that, oh, you need to take medication or, oh, you should seek care. So over the long run, patients may just forget to follow through with NCD care actions, especially if they have a lot of other things going on in their lives. There's the issue of present bias, and I think this really translates to the benefits of these lifestyle changes are difficult and they really only accrue very long in the future. So individuals might say, yeah, I would love to lose weight, but when the moment comes, because they're not getting immediate feedback on that behavioral change, they often don't do it or they put it off. The third, though, is I think a little bit more pernicious. And this is what we refer to as biased beliefs or mismatched mental models. If individuals really seek and adhere to medical care based on an infectious disease mindset or a mental model, it's really mismatched with the type of things they need to do for NCD care. So that may actually lead them to try to treat NCD care in the way they treat infectious disease care. And that would lead to a lot of suboptimal behaviors. And I'll talk more about this in the next slide. So to try to understand some of these issues, my colleagues, Dr. Mo Ali and Margaret McConnell again, we conducted a survey in 2019 of individuals with hypertension in Chennai. And these are individuals with diagnosed hypertension. So these were not undiagnosed people. Everyone in our sample was diagnosed by a physician. And we were looking around 800 people across the entire city. And we basically wanted to know what's maybe behind these gaps in hypertension control that we were seeing in the larger scale surveys. So the first thing we saw was that there was kind of poor knowledge on why blood pressure should even be controlled. So even among those that are diagnosed, only about a third knew that hypertension led to stroke, and less than a half knew that it led to heart problems. So right away, in terms of knowledge, there was this really big barrier right off this top. But then if we move to these type of belief mental model type questions, people didn't really view medication as the most important way to control hypertension. So ask them, what do you think is the most important way to control blood pressure? Or what do you think is the most effective? Or what do you think are even the top 3 most effective ways? And what we found pretty shockingly is only about a quarter of people said that blood pressure medications are the most effective way of controlling blood pressure. And only about half said that they even show up in the top 3. So basically everyone, if you're curious, said that it was all about stress reduction, followed by dietary change. So the interesting thing about this is there's this really strong social belief around stress reduction that's not really borne out very strongly in the literature in terms of like actual trials of stress reduction techniques. The ones that do show benefits show kind of small benefits on blood pressure, not to the huge extent that say medication would. And then the other belief that we had, which again links to this idea of like the type of treatment you would take for infectious conditions, a lot of people said that they think blood pressure medication should be stopped from time to time, that they shouldn't be taken continuously. Related to this, a bunch of people in our sample, 151, so about 30% of our people of our sample had completely discontinued blood pressure medications. So this was interesting. These are people that were taking blood pressure medication at some point, but then discontinued it. And when we simply asked them, why did you discontinue it? And we asked this as an open-ended question. So we didn't prompt individuals and try to lead them in one direction or the other. Basically, everybody said it was, well, it's because my blood pressure went back to normal and was cured. And therefore, I don't need to take blood pressure medication again. So again, this is relating to that kind of infectious disease mental model that you take a medication until you're cured and then you stop, which is really not the case for NCDs. So when we looked at this, and this is the last thing I'm going to talk about today, and I apologize again for jumping countries, but this study was going to be for Indonesia, but we want to try to do a parallel study in India as well. Given these type of belief challenges that we have, the last thing we were thinking about is then how can we try to address some of these and improve retention in care and improve retention in treatment specifically. So I want to talk about a trial that we're trying to run with colleagues in Aceh in Indonesia, and we're exploring whether we could do this in India as well, but right now it's kind of taking off more in Aceh. And to motivate this, in addition to regular treatment, regular follow-up visits are essential for diagnosis and for control. So regular follow-up visits are really where you get your follow-up medications, where your medications are adjusted if your blood pressure is not properly controlled. They form kind of a key part of hypertension control. What we know is people are basically stopping their blood pressure medication and not showing up again. And this is a really big problem across countries. It's not just isolated to India, but I think there's this very striking finding that I always like to talk about for India, that a study where they went to people's homes, screened those that were positive, and gave them an incentive to try to show up for a visit. And less than 10% of patients with hypertension came for even one of the recommended follow-up visits. So even when you really put a lot of effort to try to reduce barriers to showing up by bringing care to the community level, by paying for it, still less than 10% of people showed up. And we see similar narratives from our partners in Indonesia, Cambodia, and South Africa. So this retention in care and retention in treatment, we think is a really first order salient issue for blood pressure care. So this is work that's with, again, a very diverse team of people. So I want to highlight Farah Dibba and Martinus from Siala Kuala University in Aceh, Pascal Gelsetzer from Stanford University, Maya Marcus from Göttingen, Anna Reuter from Heidelberg, Lisa Roge from Hanover, and Janina Steinert from the Technical University of Munich. So we had two questions in this trial that we're designing. Can information targeted at correcting beliefs improve follow-up visit attendance rate? So if we try to correct that belief, for example, that hypertension is curable, and if we tell people, no, you really need to keep showing up, it's not cured even if your blood pressure goes back to normal, does that actually change beliefs meaningfully and improve follow-up visit attendance? And rather than do this one-on-one through counselors, which is going to be really challenging in contexts with like Indonesia, where there's far more patients than clinicians, we wanted to see if we could nest this within an information system in the form of SMS messages to deliver this at scale. So SMS message reminder systems are starting to become very common, where people are just sent a reminder of like, hey, you have an upcoming physician visit. But can we also leverage that message to put some information there targeted at these false beliefs to see if they can use the SMS to change the belief or not? So really, when we're sending these messages, we thought, well, we have an opportunity here to test other things as well. Can we try to boost the salience of our reminders in two ways? The first is, can we encourage individuals to commit to a follow-up date? And this is actually based on interesting evidence that individuals are far more likely to take actions that they've committed to do. And it might be because it creates a small social cost, but it also just seems that when people plan for things, they want to follow through with that plan, so they're more likely to do it. The second nudge is if we address messages from a trusted source, like a clinician, rather than generically. So you imagine getting a generic text message that just says, you should show up for your visit, versus one that says, hi, this is your doctor, Dr. So-and-so. It's important that you show up for your visit. If it comes from a trusted source like that, does it have a stronger influence on behavior? Is it more salient to individuals than something that's like a generic robo-text message? So the way we want to look at this is we're looking at 6,000 individuals who sought care in a public primary health center and were asked to come back for a hypertension-related follow-up visit. So this is a little bit of a complicated study design, so please let me know if I can explain it again later. The first question we had, though, was does targeting specific false beliefs improve follow-up visit attendance? And how we're going to get at this is randomize individuals to receive one of 4 SMS message types. So control message, where they're just sent a simple reminder like you have in many studies, just saying like, this is a reminder that you have a visit with the doctor next week. And then 3 treatment reminders that additionally try to provide information targeted at those false beliefs that I outlined before. So one, for example, or knowledge gaps as well. So for example, targeting that knowledge gap about why controlling blood pressure is even important. Targeting that false belief that you can have hypertension even if you don't necessarily feel ill. And targeting that false belief that hypertension is curable. Even if you took your medications and your blood pressure lowered, you still need to seek care and take medications. And so by actually separating out these different beliefs into different types of treatment arms, this will also allow us to see if there's some beliefs when targeted that produce a bigger change on behavior than others. So our second question was this nudge of, does encouraging follow-up commitment increase attendance? So we're going to get at this using what's known as a factorial random design. So independent of this initial randomization, what message they got, we're going to collapse all individuals and then re-randomize them to receive either a control state, where after their visit, we don't say anything about encouraging them to commit to a follow-up date. We just say thank you and that's it. Or a treatment visit, where after they've sought care, we encourage individuals to commit to when they will come back. And we additionally remind them of that commitment in the messages that we're sending them. And then lastly, very similarly, this question of, does addressing messages from a trusted source, like a physician, increase attendance? So again, we're going to use this factorial randomization design and collapse the groups and then re-randomize them independently to one of 2 SMS message types. So some people will get a control SMS message that's just generically addressed to them that says like, hello, name. This is a reminder that you have your upcoming visit tomorrow. And a treatment message where we actually address the messages coming from the physician themselves. So hello, name. This is your doctor so-and-so from the health facility. This is a reminder that. And the thought process here again is that if the message is coming from a so-called trusted source, it might be more salient to individuals when they glance on their phone and see it than if it's just kind of one of many robo messages that's coming in. So we're looking at a very simply, in this case, in the pilot stage, did individuals come back? And we're going to use administrative records to look at this, but also conduct a phone survey in case the administrative records have some issues. So I think this is our kind of proof of concept trial. But if this works, we're going to, of course, expand it to treatment retention and ultimately people's blood pressure levels as well. But we wanted to start off with a chunk that we could break off that was actually feasible. The other thing is, because we're conducting this phone survey where we call individuals and just simply ask them, did you show up for your visit? It allows us in a more like implementation science type way to measure the pathways of impact. So rather than just did the intervention work or not, which is not always super useful, we can kind of understand why we saw the effects that we did, or maybe why it even failed. So we're going to look at, did they even receive our messages, or did they just go to kind of a spam thing that they never looked at? And if so, were these messages sufficient at changing their beliefs? Is it enough to, when you look at your phone and see a message saying that hypertension is not curable, is that enough to really overturn a widely held or deeply held belief? We don't really know yet. So we're kind of curious to see if that's sufficient, or if really this is going to take a lot more behavior change effort than the simple message. So we think this is interesting because it's using messages and information systems, not just to send reminders, but to target specific knowledge gaps and false beliefs, and to deliver behavioral nudges at scale. I think it's moving beyond that simple question of, do reminders work, yes, no, to try to incorporate behavioral theory to ask, like, how can messages be used to spur behavioral changes? Or how can messages be used to improve the salience of reminders? And the last thing, the reason I think that we're kind of very excited about this study is its scalability and population impact. Compared to, say, providing behavior change on a one-to-one, where you really need a lot of human resources, this is being done with an information system. So we think it's very low cost. So even small intervention effects can be very cost effective. And because phone penetration is quite high in these contexts, can have wide population reach as well. So we think if it works, of course, there's a lot of potential here for it to be feasibly adopted and scaled. So I'll stop right there. I know I covered a lot of things, and I'm really looking forward to your questions. If you'd like to email me, here's my email, and I'm also on Twitter kind of off and on. So thank you so much for listening, and I really look forward to your questions.
Thanks so much, Nikhil. That was really great, and you covered a ton of ground. If people have questions, you're more than welcome to come off mute, or you can also type it in the chat, and I can read it aloud as well.
Nikhil, yeah, very, very interesting experiments, all of it. The first one, vignettes and intervention. So the gaps that were there, I was just curious whether the vignettes happened first with the same set of physicians, which would have primed them probably to the actual intervention that they did, or did it happen the other way around, and how did you address that potential bias?
No, you're right that it is a potential bias. So the vignettes were done, I believe the vignettes were done second for this exact reason. So we first actually just observed the patients, and then afterwards, the clinicians were given a vignette. I think it's actually on a different day, potentially too. So in many of these cases, they were able to do it in one day, but in many days, they came back later in the week to administer the vignette to the same clinicians though.
Same clinicians.
Yeah.
I had another question on that, where we saw that always the knowledge was higher than the actual practice, except for diet. Did you get to try to understand why was that? I have a theory, but did you also kind of qualitatively discuss?
No, actually, and I would love to hear your theory. So we're designing the qualitative follow-up to this right now. So actually your input would be great here because we wanted to understand these things, and that came up as why diet? Our Cambodian counterparts say that there's a lot of widely held beliefs that diet impacts kind of everything in the Cambodian context. So that diet questions just tend to be asked a lot, but that's just like one potential theory that one person told us. So we don't have an explanation for this. So I'd love to hear what you think.
In all the health communication classes that we very similar, all that we've done, of all the things that we teach, the questions that people ask is always about diet, because for them that is the most important thing in their life and they feel they have an influence over. So that gets the maximum bandwidth in any of our sessions. And even if we are saying, okay, diet is something we don't want to stress upon, there are other things that we have a very short duration of session, it ends up taking most of the space. So probably it is patient-initiated behavior in the your vignettes case. Maybe that is something you have to explore more.
Thank you. That's actually very useful. We are, like I said, we're designing the qualitative follow-up to this. So that's something I'm definitely going to note and tell them.
Chetna, in fact, had another question. Do you want to ask Chetna, or should I?
You please ask.
Go ahead and ask.
I just wanted to know, like you talked about mystery patient design, like clinicians were they were not knowing that they were under a study. Like I just wanted to know how ethical it was. Like,
it's a very good question. So I think mystery patient studies, they've kind of become the gold standard, but they've always had this ethical challenge of the clinicians don't know they're being evaluated. Yeah. The justification has always been, so like I said, Jishnu Das and Madhukar Pai have done many of these studies in India now. The justification has always been that this information that we get from the mystery patient studies is so valuable that the slight deception to the physician is justified or worth it. We also have to take lots of protections to make sure that audits on specific physicians are not linkable to them. So we really can't make sure any data goes out that says like that specific physician didn't do these things. So they're collected in a way that they're very anonymized. So often you don't have physician names or anything like that. You just have a clinic. The other thing is there is this ethical question of if there's many patients showing up at a room with actual conditions, you're taking up time by sending a fake patient to the doctor and like essentially eating up some of the time of patients that have real conditions that need to be seen. And I think that's a very important consideration, and one that we have not figured out exactly how to contend with yet. The logic we have right now is that the consultations are so quick and we don't bombard health facilities with tons of them. So a health facility may see one fake patient or two fake patients over the course of a couple of days. So the impact on other patients is relatively minimal. But I think that if you were to send like 5 or 6 fake patients to one doctor, that would start to become a problem because you're really taking away time from real patients. But yeah, it is an ongoing ethical question. I think it's something that we have to be very careful about, and we try to justify very carefully in our IRBs around this.
So you didn't have a lot of pushback from the IRB on this?
No, actually,
Or
because
physicians ever consent, even if it's not for that particular patient? Did they give a blanket consent at the beginning, or the hospital consented? What was the model?
so we haven't run this study yet. So that's a planned study.
Oh,
So
okay.
we've run it by our ethics committees and the grant ethics committees. And so that's why we know the IRB is okay with it. But we haven't started working with it yet. The model is really the hospitals and physicians don't know anything. So, I mean, we do pay the consultation fees. So the fake patients basically show up to a hospital as if they were a real patient, and the hospitals are not told anything. So that is a little bit ethically challenging. I think the reason why it's justifiable is it's kind of a standard approach for healthcare measurement in high income countries a little bit. So when we cleared it with the ethical board at Heidelberg in Germany, they were like, yes, this is a very standard approach, of course. It got a lot more pushback in India. And I think that's something that we need to think about, especially when there was clinicians on the ethics. When we spoke with clinicians, they felt really that we should not be doing this without them knowing that we are doing this. But I think the little that we see, I do really feel that it's kind of worth it, because ultimately, if the clinicians are not doing these actions, that's something we need to know. But yeah, it is an ongoing ethical consideration.
But you say you have precedents even in India, so that's great.
Yeah, that's how we've been justifying it, is like, look at all these studies that have already been done.
So the most interesting was the behavior change communication, where you say from a specific doctor, putting the doctors, that will be very relevant to us, the learnings from that. And whenever you're having even your early findings or pilots, please do share back with us. That will be very useful. There are a lot of behavior change communication, Shadi can speak more about it, that we're also trying to experiment, that try to find out. So we're also constantly looking at study design, sample sizes that can help us understand this. Can it be some rapid feedback that we do? Can it be, does it have to be, how intensive should it be, and things like that. So yes, it'll be very useful. Those were my questions. Please, I am hogging too much other people.
Hi, Nick. My name is Sumantra. I'm from a company called Dimagi. We do technology for impact. I have more of a speculative question, because we are trying to do projects right now. And during one of the recent field visits, I saw that the COVID networks and the way, specifically in Tamil Nadu is where I'm referring to, because you also seem to have done the same, address the same geography, that the COVID systems are piggybacking on NCDs. Do you think it's going to be substantially altering the way NCDs would be addressed? Because COVID looks at comorbidities and things like that, and the field level workers are driving and looking at NCDs in a more serious fashion. It's more speculative, but I wanted to have some sort of a takeaway, if I can, for implementing it in our current.
Yeah, I guess I will tell you what I'm excited about with the. It's weird to be excited about a COVID related thing. I think what the potential benefit of this would be is that with like the Arogya Setu app, people are a lot more used to interacting with an app for a health related thing, for COVID tracking and that kind of. So I think if something like that could be transformed or expanded to do NCD monitoring as well, that to me, I think it's sort of gotten people used to the idea of using a phone and an app for a routine health checkup.
Another related question, because you did the study in Chennai, do you have any qualitative insights in terms of how the public's healthcare compares with the private healthcare? Because I've at least observed a lot of difference between the way people treat especially hypertension when it comes to private healthcare. Is the scene vastly different, or what is your gut feel on that?
Yeah, so we ran a qualitative study along with the quantitative one I presented. It was conducted by Samarth in Chennai, who are really great qualitative researchers. And I just don't want to take credit for this. So it was also led by Carolyn Kroger at Oxford. And she actually asked people about this because on paper, Tamil Nadu especially has a very good public healthcare system, but basically still everybody doesn't want to really use it. And the perception in the public is that they never have medications, they make you wait in very long lines, they kind of rush you through the entire process. So we found very negative types of perceptions of public healthcare, even in a place like Chennai, where it's theoretically supposed to be very good. So I think that was again among people that were diagnosed with hypertension. Basically, all of them said they would avoid the public unless they really had to.
Well, thank you so much again, everyone, for coming. Thank you so much, Nikhil, for sharing and explaining what otherwise can be very complex research study designs very, very clearly and eloquently. Thanks so much.